सो वी स्टार्टेड लाइक फटाफट सब लोग ज्वाइन हो जाओ। मजे का लेक्चर सुनेंगे आज। ओके, आई थिंक माय स्क्रीन इज विजिबल टू एवरीबॉडी। Let me share the screen. I'll share the link in the group. फटाफट ज्वाइन हो जाओ सब लोग। ओके ओके ओके, I think my screen is visible to everybody. Okay, let's begin the session. So in today's lecture, let us try to learn some basic points about prostate disease. And we have so many disorders which are associated with prostate disease in urology department. So we will start with a very basic case, and through the case we will try to learn most of the basic points related to urology and related to prostate disease. So we will begin the session with this beautiful case. See, a 64 years old man, 64 years old man presents to the general medicine or to the general practitioner with the complaints of poor urine flow. Patient is having poor urine flow and having to visit the toilet at least twice during the night. So patient is going to the washroom twice, at least twice in the night. That means the patient is having nocturia. Patient is frequently waking up and patient is going to the washroom. And there is no family history of diabetes, there is no history of hypertension, there is no history of prostate disease to their family, and he is taking no medications. Medication history was also not present to this patient. Now, patient has no symptoms of pedal edema as well, and the physician has performed RBS, and in RBS the sugar level was normal and the blood pressure found was 130 by 80. Okay, so this is the case. On questioning, on further questioning, the patient describes the symptoms of urinary frequency, urgency, and urge incontinence, but fever is absent to the patient. So this is the case. Just try to understand my here. The case is a male patient with 64 years, and patient has the complaints of poor urine outflow and patient is having nocturia. Poor urine outflow can be seen if patient has kidney impairment. If patient has kidney impairment, in kidney impairment we have acute kidney injury and chronic kidney injury. But here patient's pedal edema is absent, no symptoms of pedal edema. So we can't suspect that this patient is a kidney disorder patient. That is done. And patient is having nocturia. Patient is waking up in the night. Patient is having nocturia. So nocturia is the common clinical presentation, common symptom for diabetes. But when we see the RBS of the patient, it was normal. So even this symptom is not correlating with diabetes. And in history, patient is not having diabetes or hypertension or prostate disease. No one of their family members are having this disorder, and he is also not taking any medication. So, what may be the symptoms like urinary frequency, urinary urgency, and urge incontinence? What may be these symptom is indicating for this patient? These symptoms in the urology department are commonly seen with either patient has urinary tract infection, either patient has urinary tract infection, or if the patient has prostate disorder. If the patient has prostate disorder, in these two conditions only, in urinary tract infection and in prostate disorders, patient will have urinary frequency and urinary urgency, and sometimes poor urine outflow, and night at the night patient also will be having nocturia. Patient will be having nocturia. So, in this patient, we are suspecting either UTI or prostate disorder, because patient is a man. Patient is a man. In male patients, urinary tract infection is very less commonly seen, and here patient has no fever. Patient is having no fever. In urinary tract infection, if we suspect that patient has urinary tract infection, if we suspect that patient has urinary tract infection, patient will have flank pain, patient will have abdominal pain sometimes, patient will have body pains, patient will have fever, patient will have fever. So here patient is not having fever, patient is not having body pains. So the symptoms of urinary tract infection are not seen. So what we can suspect with the symptoms in this patient? We can suspect that patient may have prostate disorder. Patient may have prostate disorder. Let me repeat the point. A 64 years old man came with the poor urine outflow, and patient has nocturia, patient has urinary urgency, and patient has urinary frequency. So these symptoms are commonly seen with UTI and prostate disorder. But here patient, we can't suspect UTI because patient is not having fever. So we can suspect patient may be having prostate disorder. I think the case is clear to you all. So in this case, what investigations are required to diagnose the prostate disease, and how should we treat this patient is the question. So based on the signs and symptoms, we are suspecting that patient is having prostate disorder. And for this prostate disorder, how should we diagnose? What are the diagnostic criteria we have in the hospital to test whether patient is having prostate disorder? And if patient's prostate disorder is diagnosed, what what management should be performed with this patient? So that is the case. Now let's try to solve the case. Before solving the case, let us try to understand some basic points about prostate diseases. See, in prostate diseases, we have three different diseases. In prostate disease, we have three different conditions. We have three different conditions. The first one is benign prostatic hyperplasia, which is also called BPH, benign prostatic hyperplasia. And we have prostatitis, and third condition is prostate cancer. So these are three prostate diseases which are very commonly seen in male patients. So the first one is benign prostatic hyperplasia. Here, benign prostatic hyperplasia is commonly seen in the patients, particularly in the male patients who are above 50 years. Above 50 years. Male patients who are above 50 years, benign prostatic hyperplasia is very commonly seen, and we will try to see the clinical presentations, the diagnostic test, and pathophysiology about this condition in detail. Okay, and the second condition is prostatitis. Prostatitis is little bit different with benign prostatic hyperplasia. Prostatitis is an inflammatory disease of prostate gland. Here, benign prostatic hyperplasia, the cell size and cell number increases and the size of the prostate gland increases. But in prostatitis, the size increases, but the size is increased due to inflammation. Due to inflammation, and that inflammation is commonly caused due to infection. So prostatitis is simply an infectious disease which is characterized by inflammation and increased prostate size, which may be having the signs and symptoms of urgency, urinary frequency, nocturia, and all. Very common with benign prostatic hyperplasia. And the third condition is prostate cancer. Prostate cancer is totally different with benign prostatic hyperplasia and prostatitis. In prostate cancer, usually tumors are seen. Usually the prostate cells will start increasing their number due to the alterations in the cell DNA and RNA. And this prostate cancer is totally a different concept. In oncology, we'll study about this prostate cancer in detail. So these are three different conditions with prostate disease. Now we will try to find some more basic points, some more important things in detail about benign prostatic hyperplasia. First thing, you all know that benign prostatic hyperplasia is just the prostate size increases in the body due to increased cell size or due to increased cell number, which is very similar to prostate cancer, but it is little bit different. Now see, benign prostatic hyperplasia is very common condition in males who are above 50 to 60 years. And epidemiological studies are telling that 50% of males, for example, if we see 100 males who are above 50 to 60 years of age, in 100 males, 50% of them will definitely have benign prostatic hyperplasia. So what epidemiological studies are telling is benign prostatic hyperplasia is very common, and 50% of the cases are seen with the patients who are above 51 to 60 years, and the incidence or the prevalence is greater than 60 years of age. अगर पेशेंट 60 years से ज़्यादा है तो उन पेशेंट्स में the percentage of prevalence is more. So benign prostatic hyperplasia is very common condition. It is seen in males because prostate gland is present only in males. And one more point, see here, you can see this is a walnut. The prostate gland is roughly the size of walnut. Our prostate gland in males, the prostate gland is roughly the size of walnut. And see, just imagine, this is kidney, okay, this is bladder, and this is urethra. Just below the bladder, it is surrounded around the urethra. Let me show the image. So the prostate gland is surrounding around the the urethra. When prostate gland size increases, it will try to constrict the urethra. Just imagine, this is the prostate gland. Just imagine, this is prostate gland. Prostate gland has two tissues. The innermost tissue is glandular tissue. Glandular tissue, and outer encapsulated tissue is fibromuscular tissue. So these are two different types of tissues which are present in prostate gland. So when patient is crossing 50 years of age, the glandular part of prostate gland size increases, the cell number increases, and through that the size of total prostate gland increases. Here, let me explain you this part here. Everybody should concentrate. Just imagine This is a urinary bladder. Urinary bladder is, just imagine, this is ureter. This ureter is coming from kidneys, right? Ureter is coming from kidneys. Just imagine this is a kidney. From kidney, ureter is coming. This is ureter, and this ureter is uh, attaching to the urinary bladder, and urinary bladder. This is urethra, and around the urethra we have prostate gland. Prostate gland has two parts. I told, in the middle part, which is exactly surrounding on the urethra, is glandular tissue, and this glandular tissue has more concentration of androgen receptors. When androgen receptor is activated with androgens like testosterone or dihydrotestosterone, the size of the glandular cells or the cell number will keep increasing, and with that it increases the size of prostate gland, and by that it will constrict the urethra, and by constricting the urethra it will decrease the outflow of urine, and it will cause all clinical presentations which are commonly seen with benign prostatic hyperplasia. I think you all are following me. I'm sorry. Okay. Now, see, let me explain you the anatomical features of prostate gland. Just imagine this is bladder, and bladder, this is urinary bladder, and just below the urinary bladder we have prostate gland, and this is urethra, and this is penile tissue we have corpus cavernosum and corpus spongiosum, the spongious tissue. Okay, so here the prostate gland size increases with the elevated concentration of dihydrotestosterone. I'll try to explain you the total pathophysiology. Okay, see, actually prostatic hypertrophy is increased size of prostate glandular cells. Prostatic hypertrophy is directly related to aging process and hormone activity. Whenever patient has greater than 50 years of age, when patient is above 50 years, that is one risk factor, and the elevated concentration of hormone, particularly dihydrotestosterone. Okay, so when dihydrotestosterone concentration increases and when patient crosses above 50 years of age, patient will have risk of developing prostatic hyperplasia. Okay, this I'll try to explain you the mechanism. Actually, we have a very important enzyme which is called 5 alpha reductase. 5 alpha reductase is an enzyme which has two isoforms. Type 1 isoform of 5 alpha reductase is present in three tissues. Remember everybody, 5 alpha reductase enzyme is having two isoforms or isoenzymes in that type 1 and type 2. Type 1 is present in liver, skin and hair, whereas type 2 5 alpha reductase is present in prostate gland. So this enzyme which is present in these many tissues, what this enzyme does is, this enzyme will try to convert the testosterone into dihydrotestosterone. Testosterone is converted into dihydrotestosterone. Clear everybody? Now this dihydrotestosterone which is converted by this 5 alpha reductase enzyme, that dihydrotestosterone is 7 to 8 times more potent than testosterone. See, testosterone which is synthesized from testes, or it is also synthesized from other androgen glands, like we have adrenal cortex. In adrenal cortex, we have zona reticulata. Zona reticulata produces testosterone, and testis also produces testosterone. The testosterone which is synthesized in males particularly, it is also synthesized in females. It will try to enter into the tissues wherever 5-alpha reductase enzyme is present. 5-alpha reductase enzyme is present in 4 tissues. One is liver, one is skin, and one is on the hair follicles, and finally on the prostate gland. In the prostate gland, the testosterone enters into the prostate gland, and this 5-alpha reductase type 2 5-alpha reductase enzyme converts testosterone into dihydrotestosterone. This dihydrotestosterone goes and binds on the androgen receptors of, we have prostate gland. In prostate gland we have glandular prostate tissue. Inside we have androgen receptor. So this dihydrotestosterone acts on these glandular androgen receptors, and through that it increases the size, it increases the hypertrophy of glandular cells, and through that it increases the size of prostate gland. And when prostate gland size increases, it will constrict the urethral tube, it will constrict the urethral duct. And when urethral duct is constricted, it will cause urinary symptoms. Clear, everybody? I think this point is clear. Now let's go back to understand few more concepts. See, when patient has benign prostatic hyperplasia due to dihydrotestosterone elevated activity, the prostate gland enlarges first. When prostate gland enlarges, it compresses the urethra, as we have already discussed, and this will lead to two symptoms. Number one, it will cause bladder outflow obstruction. It will cause bladder outflow obstruction, number one, which is also called BOO, and it will cause lower urinary tract symptoms, which is also called lower urinary tract symptoms, LUTS. Okay, so these are two main symptoms which are caused due to increased prostate gland size. Clear, everybody? Now the urinary tract symptoms, lower urinary tract symptoms, are very commonly seen with benign prostatic hyperplasia, and those symptoms are again divided into two types. Number one, the lower urinary tract symptoms. The lower urinary tract symptoms are divided into two types. Number one is irritative symptom, which is also called symptoms of failure of urine storage. Just imagine, this is a bladder, this is a urinary, this is a urethra, and from urethra it will be ejected out. So the first lower urinary tract symptom is failure of urine storage. The urine storage which is stored in the urinary bladder is failed. That is one symptom which is also considered as irritative symptom. And the second symptom of lower urinary tract symptoms is it will cause the obstruction in the bladder or obstruction in the urethra, and through that it will stop the emptying of the bladder. First one is irritative symptom, and the second one is obstructive symptom. Let's see the common symptoms. In the irritative symptoms, we have urinary frequency, patient will have nocturia, and patient will have urgency. So these three symptoms are associated with irritative bladder symptoms. And obstructive symptoms are poor urine flow. Patient will have hesitancy. Patient will be hesitating to urinate, and patient will have post-micturition dribble. At the end of the micturiation, at the end of the urination, patient will show some dripples. Okay, and sensation of incomplete emptying. Patient बार बार वॉशरूम जाते रहता, बार बार पास को जाते रहता, and patient will be feeling incomplete. एक बार यूरिनेशन होने के बाद पेशेंट कंप्लीट नहीं फील होता, patient will feel that it is incomplete, or after few minutes again patient will come to washroom. So frequently patient will be urinating. That is called sensation of incomplete emptying. And the obstructive symptom, this one is very 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 important. Here sometimes what happens, when patient has irritative symptoms and obstructive symptoms, when urethra is totally constricted, when urethra is totally constricted due to the benign prostatic hyperplasia, patient will have acute retention of urine requiring emergency. Bladder पूरा fill हो जाता, bladder will be totally filled and urine will not be passed through urethra, and that condition is emergency condition, which is commonly an acute one. So in that conditions what we have to do, immediately we have to treat the patient. In these conditions drugs are not that effective. In drugs we can go with alpha blockers, but apart from the drugs we can go with a surgical intervention which is called Foley's catheter. So this is a Foley's catheter. Foley's catheter is inserted into the urethra, and through that the fluid or the urine is removed out of the bladder. So this is the emergency technique which is used to remove the fluid from the acute filled bladder. Now, just we are suspecting, if we suspect that patient had prostatic disease or patient is having benign prostatic hyperplasia. So in benign prostatic hyperplasia patient, what common presentations or what common investigations we have to perform? In investigations we have physical examination and lab examination. In physical examination, the first one is we have to perform a very simple procedure called digital rectal examination. So this procedure is called digital rectal examination. Here the examiner will try to palpate, will try to insert the finger through the urethra, through the rectum, not urethra, the examiner will examine the prostate gland by placing the finger through rectum into the rectal cavity, and through that he will feel the tenderness or he will feel the size of prostate gland. If the prostate gland size is increased, we can easily find that patient is having tenderness or patient is having elevated or increased prostate gland size. So this is one simple procedure. The examiner will understand how to perform the test and how to identify if patient has benign prostatic hyperplasia. And the second test is transrectal ultrasonography. Through the rectum we will send ultrasonography, and through that we will try to find out the size of prostate gland. And furthermore test what we can perform is, there is a test called PVR. It is called post void residual volume, PVR volume. PVR volume. PVR volume is a test. Actually, see, when a person urinates, the bladder is totally emptied. Okay, after complete urination, the bladder will have a small amount of urine left in the bladder. A small amount of urine that will be left in the bladder. That volume is called post void residual volume. Let me repeat the point. When patient goes to urination, when bladder is filled, we will have the sense of urination. When patient urinates completely, at the end of complete urination, a small amount of urine is left over in the bladder. That leftover volume of urine is called post void residual volume, and the post void residual volume should be around 50 to 100 ml. 50 to 100 ml. Roughly it should be between 50 ml only. It should be 50 ml. That is the normal range of PVR volume. But When patient had benign prostatic hyperplasia, the urethra is constricted, and after urination the total bladder is not emptied, the total volume is not removed from the bladder, so the PVR volume will be slightly elevated. If PVR volume is more than 50 or more than 100, if it is more than 100, we can suspect that patient is having benign prostatic hyperplasia. This is one test, and ultrasound scan is commonly seen. Ultrasound scan is commonly done in the patients. Prostatic ultrasound scan, whole abdomen scan, and a part of abdomen scan. Prostatic ultrasound scan is one common ultrasound scan we can perform. Transrectal ultrasonography, which is called TRUS. Transrectal ultrasonography. The ultrasonography is sent into the rectal cavity, and through that we will find out the size of prostate gland. And there is another procedure called cystoscopy. A cystoscope, a camera is sent through the urethra. You can see the image here. It is cystoscopy. Cystoscopy also can be performed to see the size of prostate gland, and sometimes urine analysis is seen. Okay, prostate specific antibody. Prostate specific antigen. This is very important. Prostate specific antigen is the another common diagnostic test that will help us to understand the benign prostatic hyperplasia. And in very few cases, if patient is already having BPH, we can perform urine culture test, because BPH is again it will have complications of infections. So all BPH patients may have infection. To rule out the infection or to find out if any risk of infection, we will perform urine cultures also. So these are different tests which are usually performed to diagnose if patient has if patient has prostatic disease or benign prostatic hyperplasia. And next we'll try to see the treatment. Once once if patient is diagnosed with benign prostatic hyperplasia, we have three strategies of treatment for BPH. We have three strategies for BPH. Number one, first strategy is we should not show any intervention to the patient. Just we have to keep waiting. We have to watch the patient. First intervention, if patient is mild or if patient is moderate, we should not give any drugs or we should not perform anything. So this is one strategy, because mild moderate cases, after few days the benign prostatic hyperplasia is commonly reversed. Okay, and the second strategy is pharmacotherapy. In pharmacotherapy we have some medications, some drugs. We will discuss in detail about pharmacotherapy. And the third strategy is surgical treatments. If first strategy and second strategy is failed, we will go with third strategy, which is surgical treatments. Or surgical treatments are also can be done directly if patient situation demands, if patient's condition is worsening, or if patient condition is very acute, or if patient's pharmacotherapy is not effective. In that cases we have to go with surgical treatments. In surgical treatments, we have three more strategies. Number one, there is a condition called transurethral resection of prostate. Transurethral resection of prostate, which is also called TURP. This procedure is very commonly performed in hospitals. Transurethral resection of prostate is nothing but through urethra we will send a blade, a thin blade is inserted into the urinary bladder, and there we will try to remove, or we will try to cut down, or we will try to scratch away the excess growths of prostate gland. Let me repeat the point. Transurethral resection of prostate is a procedure where a thin or a very thin blade is inserted from the urethra and the excess growth of prostate gland is scratched out. So you can see the image here. So this is the TURP procedure. And the second surgical strategy what we can do is open prostatectomy. Open prostatectomy is the procedure where the direct opening of the prostate gland is done and the prostate gland is removed. It is somewhat risky procedure and complicated procedure, and more bleeding is seen here. In second procedure, in open prostatectomy, more risk, more complications and more bleeding is seen. Because of that reason, we are not commonly performing open prostatectomy nowadays in the hospitals. And the third strategy is novel strategy or the new strategies. This third strategy is transurethral microwave heat treatment. It is a type of laser treatment. Here the microwaves are sent from the urethra and heat is generated on the prostate gland, and through that the excess formed prostate gland is evaporated. Prostate gland is evaporated. That treatment is called transurethral microwave heat treatment. This treatment has less bleeding. This treatment is very easy to do, and this treatment is very advanced therapy, and it is very easy to heal as well. So transurethral resection of prostate, TURP, and open prostatectomy, both the treatments are less effective than transurethral microwave heat treatment, which is the advanced therapy and which is the novel therapy and which has less complications and very easily it heals the patient. So TUMT is nowadays we are commonly performing this test, this procedure. Okay, so these are three treatment strategies, surgical strategies for benign prostatic hyperplasia, and we are not surgical specialist, we are pharmacotherapy specialists. We will discuss about pharmacotherapy in detail. So in pharmacotherapy, we have alpha 1 blockers and 5 alpha reductase inhibitors. So these two drug strategies are very commonly used strategies and very effective strategies for the patients who are having benign prostatic hyperplasia, or it is also can be used prophylactically if patient has symptoms of BPH or if patient is above 50 years. So, before understanding the pharmacotherapy, let us try to find some precautions or some advices which can be performed for mild to moderate conditions. As I was telling, the first strategy, we should neither give drugs nor we should go with surgery. In mild to moderate cases, just we have to keep the patient and we have to see, just we have to wait and see. In those cases, what we have to do is we should try to advise non-pharmacological treatment options. In that, we have to advise the patient to take less amount of fluid just before going to bed or just going outside. So in that case, what we can do, if patient takes limited amount of fluid at the bedtime, we can restrict nocturia or we can stop nocturia in the patient. So we can stop the symptoms of the patient, number one. And we have to advise to restrict alcohol and caffeine. Alcohol and caffeine, both the overuse can aggravate the condition, and we can easily manage the constipation of the patient. So we have to advise the patient not to consume alcohol and not to consume caffeine. And the third point is we have to we should try to give the medications, or whenever patient is taking medications we should try to avoid them. For example, diuretics are some drugs which will affect the urinary system, which will increase the diuresis. If a patient is taking diuretics, we have to advise the patient not to use diuretics because patient is already having urinary symptoms. If diuretics are taken, patient may aggravate the urinary symptoms. And bladder training, we have to go with bladder training. So this is another very simple test. We have to encourage the patient to not to frequently go to the washroom. We have to advise the patient to stay for some time, and we have to advise the patient to go from time to time. We have to maintain the time. If patient is going in the morning, we have to advise the patient to go next time after 2 to 3 hours, and that should be maintained every day. Through that, bladder training is done, and that is also very beneficial strategy for benign prostatic hyperplasia, particularly in mild to moderate patients. And use of distraction techniques, we should be squeezing the penile tissue, and we have to go with some exercises, penile exercises. Even that also can show beneficiary effects to the patient who is having benign prostatic hyperplasia. Okay, so these are the advices that can be given to patients who are in mild or moderate cases. Next, let us try to understand the pharmacotherapy. Before understanding the pharmacotherapy, let us see some basic points about pharmacology. See, we have alpha receptors. In alpha receptors, we have alpha 1 and alpha 2. Alpha 1 receptors are mainly located in blood vessels, pupils of the eyes, in the pylorus, we have sphincters of GI tract. Alpha 1 are present in sphincters of GI tract. Alpha 1 are present in the sphincters of urinary tract. Let me repeat the point. 1 in blood vessels, 2 in eyes, 3 in GI sphincter, 4 in urinary sphincter. So these four are very important locations of alpha 1 receptors. Alpha 2 receptors are located in two different areas. It is present in presynaptic nerve and it is present in postsynaptic nerve. Anyways, we will not discuss about these alpha 2 receptors, which are totally different with benign prostatic hyperplasia. We will focus on alpha 1. Let me tell you some more locations here. Alpha 1, particularly alpha 1 is located in smooth muscles of blood vessels. Through that, it causes smooth muscle contraction of blood vessels, and through that, it increases blood pressure. This is one action. As I told, alpha 1 is also present in eyes. When alpha 1 is activated in eyes, it causes dilation or mydriasis. It causes the dilation of pupil, and it is also present in hair follicles. It is also present in prostate gland, and very less commonly it is present in heart also. Particularly in heart, we have beta 1 adrenergic receptor. Alpha 1 adrenergic receptor is less commonly seen, but beta 1 adrenergic receptor is very commonly seen in heart. If alpha 1 and beta 1 both the receptors are activated, it will increase the force of contraction, it will increase the AV conduction velocity, and it will increase the cardiac output, and further it will cause elevated blood pressure. It will increase blood pressure. So these are different locations of alpha 1. So alpha 1 receptors are again categorized into alpha 1A, alpha 1B, and alpha 1C. So these are another subtypes. About these subtypes, I'll tell you in detail. Let us try to see those subtypes also. Anyways, before understanding those subtype of alpha 1 receptors, let us try to find the drugs which are considered as alpha blockers. In alpha blockers, actually, when we study the pharmacology, in pharmacology, alpha blockers, we have alpha 1 blockers, alpha 2 blockers, and in that we also have unspecific alpha blockers. Unspecific alpha blockers. We will not discuss in detail about all those drugs. We will try to discuss about specifically alpha 1 blockers. In alpha 1 specific blockers, we have ALFUZOSIN, doxazosin, PRAZOSIN, TAMSULOSIN, TERAZOSIN, and silodosin. So these are the different drugs which are considered as alpha 1 blockers. And here there is a drug called TAMSULOSIN. Tamsulosin is very specific to alpha 1A. Alpha 1A is mainly located in prostate gland. So specifically, if we can block the alpha 1A receptor of prostate gland, the alpha 1A receptors will cause relaxation of prostatic smooth muscles or relaxation of urethral smooth muscles, and through that it will easily allow the urine to pass from bladder into the urethra. So alpha 1 blockers or drugs, those are very much commonly used for benign prostatic hyperplasia. So this is one class of drugs which is commonly used to relieve the symptoms of BPH, and the second class of drugs are 5 alpha reductase inhibitors. As I was explaining you in the pathophysiology, 5 alpha reductase inhibitors, 5 alpha reductase enzymes are the enzymes which will convert the inactive form of testosterone into active form or effective form of testosterone, which is called dihydrotestosterone. And in 5 alpha reductase inhibitors, when this enzyme is inhibited, it will stop the act, reduce the conversion of it will reduce the conversion of testosterone into dihydrotestosterone. And in these 5 alpha reductase inhibitors, we have two drugs. One is finasteride and one is dutasteride. Okay, so these are different drugs which are commonly used in pharmacotherapy of prostatic hyperplasia. Let us try to see in detail about each drug in BPH. The first one is prazosin. Prazosin is unspecific alpha 1 blocker. It is not specific. It lacks the specificity to alpha 1A receptor. It can block alpha 1A, alpha 1B, alpha 1C, and all other alpha 1 receptors. Okay, and when prazosin is given, it has few side effects. In that, you should remember drowsiness, it will cause weakness, it will cause headache, and very very important side effect is postural hypotension. Postural hypotension is very commonly seen adverse effect with all alpha 1 receptors. Why postural hypotension is seen with all alpha 1 receptors is because alpha 1 receptors are mainly concentrated on the blood vessels. When alpha 1 receptors are blocked, the blood vessel will be dilated, which will cause vasodilation. And when patient is from the patient is in sitting position, or if patient moves from one particular position to other position, suddenly if the patient stands up, patient will have hypotension, and through that blood pressure will be fallen down rapidly. That will cause postural hypotension, and patient will have blackouts, patient will fall down. With that, patient may develop stroke related symptoms and kidney related symptoms. So when we are using prazosin or when we are using alpha 1 blockers, we have to monitor postural hypotension to the patients, and this postural hypotension is very 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 commonly seen for the first dose of alpha 1 blockers. When first dose of drug is given, we have to advise patient to stay in one position only. We should not advise the patient to keep sitting standing, because patient may have postural hypotension and it may aggravate the patient's condition. Hypotension is very dangerous condition. So these are important points we have to remember about prazosin. The next drug is terazosin. Terazosin is also very similar to prazosin, but here what difference we have is it is a long-acting drug. Because of its long-acting activity, we can go with single dose on single day. Okay, this is one important point. And dose titration is very much necessary because it also causes postural hypotension. And adverse effects are very commonly seen with terazosin are as if prazosin. It will have same symptoms like prazosin. Okay, and frequently, uh, usually the symptoms of terazosin are less common than prazosin. And the next drug what we can see for benign prostatic hyperplasia as alpha 1 blocker is Indoramin. Indoramin is another drug. Actually, this drug is not that much used in hospital because indoramin has very high first pass metabolism and its duration of action is also very low. That's why we don't use it very commonly. So it is not necessary for us to study in detail about indoramin. One thing is, it is also a alpha blocker, it is also having same adverse effects, and its duration of action is very low because of its high first pass hepatic metabolism. And next one is doxazocin. The doxazocin is also a long-acting drug. Every day single dose is enough for the patients. And uh, while starting the treatment, we have to make sure that patient is having postural hypotension. Same like prazosine and terazocin. Okay, this is another important point about dexazocin. And the next drug from alpha blockers is tamsulosin. As I was explaining, tamsulosin is particularly specific to alpha 1A receptor. So alpha 1A receptor is present in prostate gland. Okay. So when tamsulosin is given, due to its specific actions, it is commonly used in BPH. And one more important point, its duration of action is also very good. It can be given single dose in a day, and its T half is 13 hours, and it is very well tolerated. This is very important point. It is very well tolerated because toleration is related to the adverse effects. It is it is having postural hypotension only at first dose, and from the remaining doses it is not having that much postural hypotension, and other adverse effects like headache, weakness and all is not that much seen as if we are seeing for prazosine and terazosine because of its specific action. And one very important adverse effect what we can suspect with tamsulosin is patient will have intraoperative floppy iris syndrome. Intraoperative floppy iris syndrome. This syndrome is seen in cataract surgery. In cataract surgery, for example, a patient is already a known case of BPH, and patient is already using tamsulosin. These patients, they should not be performed with cataract surgery. अगर cataract surgery करना है तो we have to stop tamsulosin 1 to 2 weeks prior to cataract surgery. If tamsulosin is continued with cataract surgery patients, this condition, intraoperative floppy iris syndrome, is commonly seen, and because of this condition, the surgical procedure may be interrupted. So this is one important point we have to concentrate while giving tamsulosin. Same like aspirin. When we start aspirin therapy should be stopped 8 to 8 to 15 days 8 to 15 days before any surgeries were performed. Dental surgeries जो भी है, whatever surgeries are done, we have to stop aspirin therapy before 8 to 15 days because it may cause bleeding. In the same way here also, in BPH, tamsulosin should be stopped if patient is having cataract surgery. I think this point is clear to you all. I'm sorry. Next drug is alfuzosin. Alfuzosin is another alpha 1 blocker. It is also not that much commonly used, but alfuzosin displays a higher selectivity for prostate compared with tamsulosin or doxazocin. See, alfuzosin is having higher selectivity than tamsulosin, but its half-life is 5 hours. And it's usually this alfuzosin, one point you have to remember is alfuzosin has very rapid onset of action, unlike other alpha blockers. Alfuzosin has rapid onset of action, T half is 5 hours, and it is having high specific action on alpha 1A receptor. Same like tamsulosin. Okay. So this is another point about alfuzosin. And yeah, these are the commonly used drugs in alpha 1 blockers. In alpha 1 blockers, as we have seen all these drugs, remember one thing, in hospitals and in many research studies, tamsulosin is the very commonly used drug because of its high tolerability. Because most patients are tolerating very well, it is having less adverse effect, and it is very specific to alpha 1a block, alpha 1a receptor, and due to its longer duration of action, tamsulosin is most commonly preferred drug for benign prostatic hyperplasia. Okay. Now next we will go with 5 alpha reductase inhibitors. In 5 alpha reductase inhibitors, as we have discussed, we have two drugs, one is finasteride and one is dutasteride. Finasteride and dutasteride both are same drugs, both are known drugs which will inhibit 5 alpha reductase enzyme. When the enzyme is inhibited, it will stop the conversion of testosterone into dihydrotestosterone, and when dihydrotestosterone is decreased, it will show limited action on prostate gland, and through that also we can stop the elevated or increased size of prostate gland. And when 5 alpha reductase inhibitors are given, dihydrotestosterone activity decreases, and the second beneficiary action what we can see in males is we can stop male pattern baldness. Okay, alopecia, we call it alopecia. Actually, alopecia or the baldness is commonly seen when dihydrotestosterone activity is elevated. Due to elevated dihydrotestosterone activity, patient will have alopecia. And in alopecia conditions, in hair loss conditions also, 5 alpha reductase inhibitors are commonly used. That is one beneficiary point we can add with the male patients. Let us try to see in detail about finasteride first. Okay, finasteride, see, I was explaining you, in 5 alpha reductase inhibitors we have two forms. Okay, one is present in liver and the second one is present in prostate gland. So finasteride is a type 2 5 alpha reductase inhibitor that reduces the prostate size by 30%. So finasteride is specifically, it is inhibiting the enzyme which is present in prostate gland, and it is not inhibiting the 5 alpha reductase inhibitor which is present in liver, skin and in hairs. Okay, so if a patient is having alopecia, finasteride should not be given. And if patient is having benign prostatic hyperplasia, finasteride is to be given. Why, I will tell you the point while comparing the dutasteride. And the side effects of these drugs are, finasteride will cause decreased libido, the sex drive, or the sexual activity will be decreased due to finasteride, because finasteride is decreasing the active form of dihydrotestosterone. It may also cause impotence. It will cause reduced ejaculatory volume. The volume of ejaculations will be decreased, and less commonly, finasteride will cause gynecomastia. Gynecomastia is elevated breast size in males, or breast development in males. That is called gynecomastia. All these symptoms are seen because the active form of testosterone, dihydrotestosterone, is decreased, and the female hormones domination increases like estrogens and progesterones from the males. Through that, patient will have feminizing characters like decreased libido, impotence, reduced ejaculatory volume, secondary sexual characters will be decreased, and patient also will have gynecomastia when finasteride is commonly used in males. So one important point you have to remember, finasteride, irrespective of its beneficiary actions on male pattern baldness, it should not be given to recently married men. Okay, so this is important point we have to focus on finasteride. And one more very important point, previously we were discussing prostate specific antigen. Prostate specific antigens are the antigens which are diagnostic criteria for BPH. When finasteride is given, 50% of prostate specific antigens are decreased, and through that it will decrease the benign prostatic hyperplasia. This is another very important action of finasteride. So important points you have to remember about finasteride is it is a type 2 blocker, type 2 5 alpha reductase inhibitor, and it has all feminizing activity, these symptoms, and it decreases the prostate specific antigen. And the second drug is dutasteride. Here the difference between finasteride and dutasteride is dutasteride inhibits both type 1 and type 2 isoenzymes of 5 alpha reductase. So finasteride is specific for benign prostatic hyperplasia, and dutasteride is specific for male pattern baldness. Because male pattern baldness, the type 1 5 alpha reductase enzyme is present in liver, it is present in skin as well as in the hairs, whereas type 2 is present in prostate. Because of that reason, finasteride is drug of choice in BPH and dutasteride is drug of choice in bald male pattern baldness or alopecia. Okay, and both of them are having same action, but dutasteride is more potent. Dutasteride inhibits both the enzymes. Okay, this double inhibition can reduce serum dihydrotestosterone level by 90%. Because it is inhibiting both the enzymes, 90% of dihydrotestosterone is decreased in the body, and dutasteride decreases prostate volume by 26%, which is very less compared with finasteride. And, and dutasteride therapy can decrease the size of prostate gland after 6 months. We can easily see the lower unit tract symptoms are relieved when these drugs are given. And one thing you have to remember, alpha 1 blockers are used for relieving the symptoms, whereas 5 alpha reductase inhibitors, dutasteride and finasteride, are used to decrease the size of prostate gland, and this decrease in size cannot be seen in single day or in a week. It will take 1 to 6 months, and this treatment should be continued up to 6 months, and we can see the results only after 6 months usage of the course. And dutasteride is well tolerated when compared with finasteride. Dutasteride is well tolerated. All the side effects are very common as if finasteride. Okay, erectile dysfunction, ejaculatory dysfunction, breast enlargement are very similar with dutasteride as well. So one more important point here we have to remember is dutasteride, despite of its both inhibiting activity, the most commonly used 5 alpha reductase inhibitors is dutasteride. Let me repeat the point. The most commonly used 5 alpha reductase inhibitor is dutasteride, and dutasteride is very commonly used with combination with alpha 1 blockers. Okay, which is called combination therapy. Next we have combination therapy. Tamsulosin plus dutasteride. There is a brand called Urimax D. Urimax D. Tamsulosin plus dutasteride is one formulation. Tamsulosin plus finasteride is one formulation. Tamsulosin plus finasteride is another. Uridax F. We have Urimax F, Urimax D. Okay, and tamsulosin plus dutasteride is another modified release tablet, because tamsulosin is having long activity and dutasteride also. Dutasteride, to show its long activity, we will formulate them in modified release tablet form, which is called CFlow D. Okay, so these are combinations which are given to the patients, and in few research studies what they are telling is when drugs are given in combination, like 5 alpha 1 5 alpha alpha 1 inhibitor and 5 alpha reductase inhibitor, for example tamsulosin plus dutasteride, the combination therapies are having more efficacy than when patient is using individual therapies. Okay, so because of this more effectivity, when a patient is having BPH, these combination therapies are very commonly given. So that's it about prostatic disease. In the next lecture, I'll come with prostatitis and with prostatic cancer. Until then, see you. Thank you all for joining my lecture. Keep sharing my lecture. Please don't forget to like and keep sharing this lecture to your friends and other medical professionals. Thank you all.